I'd like to thank all of our speakers for outstanding discussion today. Dr. Hurtado, Dr. Bajgaz, Dr. Eisen, Dr. Barshak, we really appreciate all your insights. We're going to go through and have a fairly rapid fire Q&A. We have just over 20 minutes, and we're going to start with Dr. Hurtado. So, Dr. Hurtado, if a patient develops elevated transaminases on INH rifapentine for latent TB, what therapy would be safest to initiate? She's about 6 weeks into therapy. She's a household contact of a person with active TB, and now her transaminases have normalized. How do you handle this situation?
Thank you for a great question. This is not an uncommon scenario in general with TB therapy. Just a reminder that there is some synergistic toxicity in the use of rifamycins with isoniazid. The rates overall of hepatotoxicity for this regimen of severe requiring discontinuation are a little under 1%. It's actually quite similar to the rates with rifampin. In this particular case, one cannot, and many of these are idiosyncratic, and many patients are able to tolerate reintroduction. What I would personally do is once the liver settles, and again, a reminder that latent TB is typically not an emergency latent TB therapy, I would probably move away from the same combination and just use rifampin alone. The rate of rifampin hepatotoxicity is less than 1%. Many patients are able to tolerate cross rifamycins. So that's what I would do. Thank you.
And you might monitor a bit more closely in the first couple of weeks just to make sure things are good.
Absolutely. And educate the patient about the signs and symptoms, which are often very nonspecific. So remember, fatigue is a very common sign of anorexia above and beyond your baseline. Thank you.
Dr. Bajgaz, an amazing talk. One of the participants is interested in your perspective on an acute respiratory infection, viral or bacterial. How long might one wait to evaluate for possible NTM? That is, presumably if you have ongoing symptoms, is there a period of time that you should wait before either evaluating for NTM or considering treatment of NTM?
Thank you, Dr. Gandhi. I think it depends on the host and the clinical presentation you suspect. So if it's a profoundly immunocompromised host, or if they have extensive disease of the lung that you think might be attributable to MAC, then I would evaluate early. And otherwise, if they meet none of those criteria, I often wait until the symptoms of the acute inflammatory infection are better, because in my experience, having sticky airways from inflammation and from mucus production is associated with an increased risk of colonization for MAC. So an example would be, I would probably try to wait 8 weeks in an average viral or bacterial infection that precedes MAC.
Got it. Thank you. Dr. Eisen, this is your first year in our course. Thank you for your excellent talk. Could you say a little bit more about the home test for respiratory viruses that are available in the US? Are there patients who would benefit for a home flu test, RSV test, not just COVID? What's available? What are the options?
Yeah, so home tests really fall into two different categories. There's the rapid antigen test that I think all of us got used to doing for COVID-19. And then there are rapid PCR tests, and there's just a few of those on the market. One of the challenges with the rapid antigen test for some of the viruses, like RSV, their sensitivity in adults is with assays is pretty low. And so they're not currently recommended to screen adults for RSV. They're very sensitive in young children, and so can be used in those patient populations. For flu, there are rapid antigen tests that are available that can be used. It is important to recognize that if you're not feeling well and you're concerned about flu and the test is negative, that you should call your doctor and or reach out to a clinician to get additional PCR testing, and particularly if they're a high-risk individual or immunocompromised. And that's because the sensitivity of these assays depends a bit on the virus that's circulating, and can be as low as 60% positivity. So it may miss up to 40% of the cases. There are newer PCR-based tests. The Lucira is the one that's most widely available, and that has similar sensitivity as hospital-based diagnostics. It currently is formulated to detect both flu and COVID-19. And so if it's negative, it probably isn't one of those viruses. The downside with the Lucira is that it's relatively expensive. I think it's about $45, and you can only do one test on. So for many patients, that's probably more than they're willing to spend.
Terrific. And for just a second, I lost the transmission on the RSV. The rest I heard perfectly well. For adults, the RSV
It's not recommended.
sufficient because of insufficient sensitivity.
Sensitivity, yeah, it's in the 20 to 30% range sensitivity. So
That are available
really not sufficient
for children.
Yep, they're available for children, and again, young kids less than 6 or so is where the sensitivity is pretty good.
Thank you. Dr. Barshak, one of our participants was referred a patient with chronic maxillary destruction underneath an infected tooth, and the patient had a biopsy that revealed numerous actinomycetes-like organisms, but the bone culture is negative for actinomyces. Is the pathology enough to consider this a proven actinomyces infection?
It's a good question. I get referred a number of people like this, and there are a few important details that can help to test that out. So actinomyces is a normal inhabitant of the world space, and so many of us have actinomyces living there all the time. The first important question is, what kind of piece of bone sample was this? Is this dead bone that may just be colonized by oral flora, including actinomyces, which is distinct enough for the pathologist to comment on it because of its morphology? Or is this live bone that really looks like it has actinomyces invasively living in it? And often the pathologist can be helpful with that. The second thing that can be helpful in interpreting the distinction between what you see on the pathology and what's growing in the culture is to get a sense about what antibiotic exposures the patient may have had before the samples were taken. Actinomyces are kind of notoriously difficult to grow in culture, and even a single dose of something like amoxicillin, which the oral maxillofacial world tends to use a lot of, can interfere with the ability to grow the organism in culture. So if this story sounds suspicious and the pathology looks suspicious, I would imagine that it might well be a real infection that was not growing in culture because of prior exposure to antibiotics, and would assume that this may be a real infection. The question then becomes what to do with that, depending on what was done in the surgery. If this was kind of surgically cured in an otherwise healthy patient, it might not necessarily require a prolonged amount of treatment, but the details are really important there. If this is a patient who's had radiation therapy and has, osteoradionecrosis underlying and is at risk for ongoing trouble from the actinomyces, then that's a more complicated decision about how much treatment might be needed.
Got it. Thank you. Back to you, Dr. Hurtado. Now we're going to switch from latent TB therapy to active TB therapy. The participant is interested in your thoughts about an empiric regimen for pulmonary TB while susceptibilities are cooking if a patient is from an area with high rates of MDR TB, not necessarily a known exposure to MDR, but from an area where there is a lot of MDR. Thoughts on that? Azurite plus moxifloxacin is sometimes used. Is that the right approach?
Excellent question. I'm going to take a step back and first just remind the audience, aside from being from a hotspot, and there are several in the world, that we should always do a quick risk assessment of that patient. So a new patient versus a previously treated patient. Previous treatment, higher risk. Anybody who's been a healthcare worker in a TB endemic area, because most of the TB elsewhere is treated as in particular, those who work in inpatient settings, a lot of chronic TB patients with complications who have higher rates of drug resistant get hospitalized. So there's good rates in parts of the world. A lot of this data comes from sub-Saharan Africa, that if you are a healthcare worker, your rates of drug-resistant TB are 5 to 6-fold higher. Anybody who's a contact of someone who died during TB therapy, or a contact of someone who received injectables. Now, we're moving away from injectables, but many patients can recall, oh yes, mom was treated for several months with an injection as part of the TB. That should all raise a red flag. With regards to the hotspots, there's actually really good resources, and I'm happy to put in a link and send to the organizers or post directly. The WHO does post by country what the current rates of drug-resistant TB are amongst new and retreatment patients. This is very helpful. There are areas of the world, I would highlight the Russian Federation, where rates of MDR-TB amongst new patients are in the 30 to 37% range. Some of the previous in former Soviet Union related countries such as Estonia, etc., will have rates in the 20s. So those are settings in whom, especially for high stakes situations, one might consider including and expanding. And typically in this current day and age, it's Moxi or levofloxacin. I'm going to stop there for others.
Moxi and levofloxacin plus your traditional 4 drugs, is that right?
Yeah, it depends on the setting. On occasion for like CNS TB, we may also incorporate linazolid, et cetera. So there's various other permutations.
Perfect, thank you. Dr. Bajgaz, do you or your oncology or your other colleagues who use immunosuppression routinely advise their patients to put on a mask when using commercially available potting mixes to lessen the chance of Legionella pneumonia? And if yes, what type of masks? If not, why not?
It's a good question and really refers to the larger question of does behavioral modification to decrease risk of exposure impact infection in these hosts? And I think I would consider this question based on 2 things. One is how much of the substance, whether it be soil or whether it be in a hot tub or pool, is likely to be either aerosolized or somehow inhaled during that activity. And there's obviously a difference between potting soil in your home and turning over soil with a tiller. And I do tend to advise people with severe chronic lung disease or people with other forms of immunocompromise that if they are going to do things that create a lot of risk for aerosolization or other environmental contact, that they do wear masks. And I think that's not just for infection, but in general for irritants. I don't routinely do it. And remember, even though we focus on soil, a lot of these organisms are in bathtub inlets, they're in shower heads, they're in water supplies in our homes. And so really there isn't a way of avoiding all exposure.
Makes good sense. Dr. Eisen, we're going to turn next to you on the hospitalized patient with influenza. What are your thoughts on IV peramivir alone or in combination with baloxavir? I've been hearing for some time about studies of combination therapy in hospitalized patients. So IV peramivir alone or in combination with baloxavir for hospitalized influenza pneumonia patients.
Yeah, so I think that's a really good question. And when we designed the Flagstone study, which studied baloxavir plus standard of care, which was mostly oseltamivir, I think all of us that were involved in the planning of the study expected the combination therapy to result in better outcomes. Unfortunately, it didn't. It did markedly reduce the viral load. So by the end of the first day of therapy, most of the virus had cleared from the patient's upper airways, at least. But if you looked at the clinical markers of outcome, there was no difference in things like amount of oxygen use, time to discharge, clinical recovery, ventilation in those patients that required it. And so for now, it seems that for the majority of hospitalized patients, monotherapy is probably sufficient and that there's very little benefit in the combination therapy. The only benefit that was shown is reduction in resistance emergence. And so if you had a patient that had higher risk, such as a stem cell transplant patient or a patient that was a solid organ patient, like a lung patient that's more heavily immunosuppressed, that might be a regimen you would consider in those patients, really not to improve outcomes necessarily, but to reduce the risk of resistance emergence. IV peramivir was studied for the hospitalized patient with a daily dose, not the single dose that's approved for outpatients, and basically wasn't approved because it wasn't better than oseltamivir, which is the requirement for FDA, but it was, in my view of the data, equivalent. So again, I think if you had a patient that you were concerned about bioavailability of oral oseltamivir, you could use IV peramivir. But again, I think the combination of baloxavir plus IV peramivir probably wouldn't give you much of a difference from what we saw in the Flagstone study.
Dr. Barshak, question that comes up quite frequently is a person who has a positive TB test, either an interferon gamma release assay or a skin test, and then has uveitis. How do you think about approach to such a patient in terms of either diagnostics or treating that patient with active TB therapy for drugs, or at some point latent TB therapy if you don't give active TB therapy?
Yeah, it's a good question, and this is a really challenging clinical scenario. A lot of the time, sometimes it's easy and you can find a way to justify active TB treatment because they have extraocular disease, meaning that our goal is usually to try to screen thoroughly and aggressively for that. So review systems for any respiratory symptoms or other sort of systemic hints about tuberculosis someplace else. Good imaging, usually not just a chest X-ray, but a chest CT occasionally can uncover something that isn't visible on a chest X-ray that's worth potentially going after with diagnostic sampling of the lungs, which is a much easier place to address that question of TB, or potentially a urine to look for evidence of, the rare possibility of renal disease. In the absence of any of those helpful clues from outside of the eye, it's really helpful to talk with the ophthalmologist about what they're seeing exactly for the uveitis. There are certain uveitis syndromes that are considered more typical or classic for ocular tuberculosis than others. So the primary location of a TB infection in the eye is typically thought to be the choroid. So things like multifocal choroiditis or anything that looked like choroid tubercles are kind of the buzzwords that you're looking for in the ophthalmologist's note. Sometimes the patients will have something called Eales disease, which is a pattern of inflammation that the ophthalmologist can describe, or more sort of granulomatous appearing anterior uveitis would be syndromes that are considered more suggestive of ocular tuberculosis and might make you lean more towards treating for active tuberculosis in those settings. But often what it boils down to is a conversation with the ophthalmologist about how worried they are about ocular TB or how confident they are about an alternative diagnosis. And in the absence of any confidence either way, I do often wind up treating people presumptively for active tuberculosis with sort of treatment as diagnosis. Usually people who really do have ocular TB get better, or perhaps first convincingly get worse, because the inflammatory response to dying tubercles can be quite significant. Usually if there's no change in the eye exam over the first couple of months, it argues against ocular TB as the true diagnosis, and they usually step back and just treat for latent tuberculosis while they get autoimmune therapy-directed treatment with whatever the immune suppression is that the ophthalmologist feels is most appropriate. But these cases are always difficult and complicated, and there's a lot of nuance involved for any particular case, so it's hard to give very generic advice about that.
Fair enough. Thank you. We're going to do one more quick round of questions, and then we'll stop for today. So, Dr. Hurtado, if you have a patient in a low prevalence area for TB, but the person has a positive TB test, for example, a skin test, but the IGRA is negative, and they're asymptomatic and a negative X-ray. So basically, positive skin test, IGRA negative, asymptomatic in a low prevalence area. How likely is it that that person has TB? And the calculator that you mentioned seems to be calibrated for INH toxicity, but we're now using rifampin. Thoughts on that?
Yes, so it really depends on a deeper history as well, and so many patients are misclassified as being low risk, and not only because of not having a full extent assessment of their comorbidities, but also by not having a full understanding of their social circles. And so the vast majority of times, the discordance is rampant, 30 to 40%. So oftentimes those patients do in fact have true TB infection. So but we should really be primarily targeting those who are at risk of progression. And so that's the key message. So we're not pan population, but progression.
Message. Dr. Bajgaz, are GI symptoms more common with Legionella? One of the participants recalls in the original description that of Legionella, GI complaints were more common, but is less sure that association is held up over time. What's your thoughts?
Thanks. Observational studies do suggest that GI symptoms and liver enzyme elevations are more common with Legionella, but this question is a good reminder that both of those can occur with many forms of pneumonia. And so they don't have terrific positive predictive value for Legionella.
Dr. And this is a fairly open-ended question, but maybe you can just give us a sense. Are there therapies in development for rhinovirus, paraflu, or metapneumovirus, particularly severe disease and immunocompromised hosts? What do you see on the horizon?
Yeah, so the drug that's the furthest along is DAS1, which is sialidase remover, basically from the cell surface. Removes the sialic acids from the surface of the cells for parainfluenza virus. It had some evidence of benefit in the phase 2 study, and the phase 3 was refined to reflect that population. So that's ongoing, and we hope to have that back. For most of the other viruses you mentioned, there's very little that's currently being developed. It's definitely an area that needs further research and effort. There are a number of drugs like remdesivir and molnupiravir that have activity against a broad range of RNA viruses that are planned to be studied against some of these viruses. And so I think that is where we'll probably see the biggest effort pushed in the near future.
Got it. The last question for today is over to you, Dr. Barshak, which is for ocular syphilis. Can you comment on your experience with how much visual recovery people will get back after they've been treated for ocular syphilis? Is it most, or is it sometimes not fully full recovery?
It's a good question for which there's also not a lot of necessarily generic input that I can give. My own personal experience is that most people do get improvement in their vision, but there are a lot of things that can play into that, including their sort of function of their immune system and how promptly they're treated, and a number of other factors that may be more difficult to delineate than that. So the sort of general answer is that most people do get some vision back, but it can be hard to predict. Not all of the vision is related, not all the vision loss is related to active infection. There's control of the associated inflammation as well. And if that isn't controlled promptly, then there can be permanent vision loss that's separate from the course of the infection itself.
Got it. Terrific. Well, I want to thank all of the speakers from this morning for both their talks, but also this really insightful discussion that we just had. We'll conclude this session for now and invite people back at 10 minutes to the hour, 12:50 Eastern time, if you're in our time zone. And we're going to start off the afternoon with a very special clinical pathological conference associated with the New England Journal of Medicine. So please join us for that, and look forward to seeing you then.